So hypertension, unlocking the dangers is a very interesting topic actually. Start with a case, a 14-year-old boy from Calcutta with with intellectual disability presents with persistent vomiting and anorexia, treated by several GPs for GRD with poor response to treatment. Examination, he's a well-looking boy, mild fellow was there, blood pressure was very high, 230 by 120, pulse of 84, with good volume, no peripheral edema. This particular patient was now say the problem with this patient is the blood pressure was not checked previously because they thought that normally it's not a practice to check the blood pressure in young people. We assume most of the time it's normal, it looks normal, but sometimes you may miss like this case. This is one of that odd case where the blood pressure was very high. So it's a young hypertension, isn't it? Now say a young hypertensive patient. So this patient needs further evaluation actually. What we did was some investigation. So hemoglobin came as 8.2, creatinine was 9.6. Sodium 136, potassium high, calcium low, phosphate high. What is your impression? CKD, there are features of CKD. The chronicity is, the anemia is there, hypocalcemia, vitamin D deficiency. Now, 1-alpha hydroxylation is not happening, and so you have the hypocalcemia. Because of the phosphate excretion is impaired, hypophosphatemia happens. So these investigations are more in favor of CKD, which is confirmed by the ultrasound KUB. Ultimately, the patient undergone KT, and then now he is well. So the message from this case is we need to check the blood pressure. So whenever you have access to pursue your patient, irrespective of age, try to check the blood pressure. So with this, so that is one. So if the blood pressure is high in young people, evaluate whether there is any underlying etiology for the highly likely. The younger the age, the more for secondary hypertension. And we need to know most of the time secondary hypertension is potentially treatable. So early detection, mainly screening in whenever you get the opportunity, whenever you visit a school or a school screening or community, a GP practice, a hospital practice, irrespective of age, go and check your blood pressure, check the patient's blood pressure. So what is the definition? Now this lecture is based on mainly national guideline. The national guideline incorporates European Society of Cardiology and European Society of Hypertension and multiple other randomized controlled trials and the Sri Lankan data. They have incorporated and made it. It's more or less similar with other international guidelines. So it would be very useful. It's very elaborate guideline. So systolic blood pressure 140 or more, diastolic blood pressure 90 or more. Then repeated examination, we need to prove that with repeated examination. So applies to all adults over 18-year-old. So this is an important slide where we can check the normal blood pressure is 130 and below and 85 and below. So if it is that, we can say it's a normal blood pressure. There's another category called high normal blood pressure. Before we are going into grade 1 to isolated systolic hypertension, the high normal blood pressure is 130 to 139, 85 to 89. You can easily take it as, now say, how do we remember these numbers? You can make 140 and 90 above is hypertension. So you take that as a grade 1, 140, 90. So add 20 for grade 1 hypertension. Now say 140 to 160, so 159. So to the systole you add 20, diastole you add 10. So you can easily remember 140 to 159, you add 20, and then 90 to 99, 10 you are adding. Similarly 160 to 180. So you are going to grade 3 or severe hypertension, 160 to 180, 179, or 90 to 100. Sorry, 100 to 110. So similarly, you add for the systolic blood pressure 20 and diastolic pressure at 10. So grade 1 hypertension will be 140 to 159, 90 to 99 diastolic. Similar grade 2 above 160 and 100. So there is a category called high normal blood pressure, which is 130 to 139 systole and diastole of 85 to 89. So this slide is important. Then only you know how you are planning your management, right? So do you want to treat the high normal blood pressure? That's the next question. So its only indication is whether the cardiovascular disease risk is more than 20%. So generally you offer the lifestyle changes like diet, exercise, weight loss, smoking cessation. You can offer that. Generally you can advise. Most of the time, the primary care physicians, you have more contact with the patients, so you can advise. You assume that they don't listen, but most of the time they listen to your advice. Ask them to reduce the salt. So if you want to quantify it, if they are making food only for one person, you can ask them to 5 gram, less than 5 gram for 24 hours, like salt can be taken. Similarly, high fiber diet like fruits and vegetables, they have to take. Weight loss program, right? Smoking, stop smoking. Okay, so you can advise them. So generally, you don't offer the blood pressure medications in this group, high normal blood pressure, unless the patient is non-patient with cardiovascular disease or having a cardiovascular risk of more than 20%. So primary hypertension develops over time, and a combination of risk factors play a role. So the risk factors are many: male sex, aging, overweight, dyslipidemia, diabetes, insulin resistance, family history of early onset hypertension, sedentary lifestyle, stress, high sodium intake, high alcohol intake, low potassium intake, and a low calcium. So you know these. So now we move on to the next case. A 32-year-old female presented to the emergency with a proximal muscle weakness. So the examination showed a febrile female. She is well looking. A blood pressure of 190 by 100, 110, pulse 90. So she had weakness, upper limb and lower limb both. Upper limb has 4 power and the lower limb has 3. Generalized areflexia, and the planters were downgoing planters. So what do you think? Yeah, and I'll move on to the examination also. So yeah, the potassium is very low. The potassium is very low. So the patient having a hypokalemic muscle paralysis, isn't it? But the creatinine is marginally high. Venous gas showing alkalosis. So bicarb of 30, metabolic alkalosis. So what is your impression on this case? Yeah, primary hyperaldosteronism, because this triad is there, isn't it? Metabolic alkalosis, severe hypertension in a young female, and hypokalemia, severe hypokalemia, isn't it? So you have to think of a primary hyperaldosteronism. So secondary hypertension you need to consider. So what are the features which say that the patient is having a secondary hypertension? Generally, younger people, right? Even though the essential hypertension or a primary hypertension is commoner in young people, but the secondary hypertension is you have to evaluate. Whenever a young patient is coming with hypertension, you need to evaluate. But still, primary hypertension is common in those age group, right? So less than 40 years, young, acute worsening of hypertension in a previously well-controlled blood pressure. So whenever blood pressure is controlled and sudden rise of blood pressure, you need to think of whether there is another etiology there. And disproportionate hypertension-mediated organ damage. So sometimes the hypertension-mediated organ damage may be very severe enough to say, with the very shorter duration of hypertension and the hypertension-mediated organ damage. I'll come later. What are the organ damage? So you have to think of an etiology for the hypertension. Resistant hypertension. Generally, resistant hypertension, we add 3 steps mainly. ACE inhibitor or angiotensin receptor blocker, that is 1. Number 2 is calcium channel blocker mainly. Yeah. The third one is thiazide-like diuretic, thiazide or thiazide-like diuretic. Whenever this particular patient is not controlled with these three, and then we are going to the fourth antihypertensive, then we call it as a resistant hypertension, right? So whenever resistant hypertension, you have to think of whether there is an underlying etiology, a cause for the hypertension. Hypertensive emergency as the first presentation. Now, say in this lady, she presented with a hypertensive emergency, very severe hypertension came with. So again, the pointers in this particular case is presented a young patient, presented with an emergency and a severe hypokalemia, okay, and metabolic alkalosis also. Onset of diastolic hypertension in older adults, unprovoked or excessive hypokalemia, then you have to think of. Sometimes the patient may be on losartan, still the patient may be losartan and spironolactone, and the patient having hypokalemia. So that is again a significant hypokalemia is there. Even though with the ACE inhibitor or ARB is added and a spironolactone, potassium spironolactone added, then the patient still have hypokalemia. So that is very significant hypokalemia. And clinical features suggestive of obstructive sleep apnea, clinical or biochemical features suggestive of endocrine causes of hypertension or CKD, right? So you need to know, and then you need to evaluate these patients. Causes of secondary hypertension according to the age group. Generally, below 12 years, 12 to 18 years, 19 to 40 years, all category, you have the renal parenchymal disease. You see in this list, renal parenchymal disease comes in all category, from young children, adolescent, young adults, middle-aged, and older adults. So whenever you are evaluating, renal parenchymal disease comes in all categories. But in young children and adolescents, coarctation of the aorta is one of the differential monogenic disorders. Young adults, renal parenchymal disease, fibromuscular dysplasia, you need to mainly, especially in women. So sometimes whenever you start ACE inhibitor or angiotensin receptor blocker, then the creatinine goes up significantly, about more than 30% rise. Then you have to think of underlying renal artery stenosis, right? You can allow up to 30% sometimes, but if it is more than 30%, a significant rise of creatinine, you have to think of an underlying, maybe due to fibromuscular dysplasia or atherosclerotic renovascular disease, bilateral, right? And middle-aged adults, you have to think of primary aldosteronism, obstructive sleep apnea, Cushing's, pheochromocytoma. So if you think of pheochromocytoma, they come with, sometimes pheochromocytoma can present with normal hypertension. No, without hypertension, they can come with hypotension also. But generally it is variable, like low blood pressure, normal blood pressure, high blood pressure. That's why episodic hypertension sometimes. They have significant sweating, palpitations, right? So those symptoms actually come with, they may come with dehydration also sometimes. So you have to think of in people who have, you are thinking of a pheochromocytoma as an etiology. Atherosclerotic renal vascular disease. All the adults, it's again atherosclerotic renal vascular disease, renal parenchymal thyroid disease. So these are the common causes. So how to measure the blood pressure? It's very difficult now, say, to make this, but it's better to try this sort of, now say, a patient has to be back supported, no talking during and between measurement, cuff to fit the arm size, right? Arm bear and resting, electronic manual, but they prefer this now, the oscillometric blood pressure measurement. Manual auscultated device, inflatable bladder of the cuff must cover 75 to 100% of the individual arm circumference. Cuff should be according to the device instruction. So it's a quiet room, comfortable temperature, no smoking or coffee, exercise, empty bladder, relax for 3 to 5 minutes. It's very difficult to so follow this sort of a setup in a busy clinic, but try to make it to minimize the error. What is home blood pressure monitoring? So generally you can ask the patients to check the blood pressure at their home. Home blood pressure is the average of all the blood pressure reading performed with a semi-automatic validated tool. should be performed at least 3 days, preferably 6 to 7 consecutive days. 2 measurements should be taken at each measurement session. So it's the average. You check the average, you discard the first reading and check all the average. So compared with the clinic blood pressure, home blood pressure monitor values are usually lower. The diagnostic threshold for hypertension is less than 135 by 85. You remember, home blood pressure monitoring, you reduce 5. What is your normal blood pressure cutoff to diagnose the hypertension is 140/90. So you reduce 5 for the home blood pressure monitoring, 135 by 85. So ambulatory blood pressure monitoring is another tool to diagnose hypertension. Sometimes you have the white coat hypertension. Sometimes the patient may be anxious. You wrong diagnose. Sometimes you can check whether the patient comes to you, if the heart rate is around 150, like 130 sometimes, they are very anxious. And then the blood pressure will come as 180, 100. It's very common whenever you check. So you know that this is due to that anxiety causing some hypertension. So most of the time, white coat hypertension, sometimes it's very difficult whether this patient having a hypertension or not. So you can ask them to check the home blood pressure monitoring or ambulatory blood pressure monitoring. You can ask them. The device is typically programmed to record blood pressure at 15 to 30 minute intervals. Average value of at least 20 measurements taken during the daytime and 7 measurements taken during the nighttime. Average blood pressure values are usually provided for daytime, nighttime, and 24 hours. So the cutoff is mainly 130 by 80, right? Daytime, blood pressure 135 by 85. Nighttime is 120 by 70. So the average is 130/80. So the average is the 130/80. You reduce it 10/10. 120/70 for the night time, and the daytime would be at 55, 135 by 85. And you understood, isn't it? So we do that ambulatory blood pressure monitoring. So it's a summary. What we have talked up to now is clinic blood pressure to diagnose hypertension 140/90 and above. Home blood pressure mean more than 135 by 85. Daytime would be 135/85, nighttime 120 by 70, and 24-hour mean would be more than 130/80. Right. Now, white coat hypertension should be suspected when the clinic blood pressure more than 140/90 on 3 separate occasions. So there are two different things actually: white coat hypertension and masked hypertension. Sometimes you can have hypertension in your clinic. The patient have more than 3 separate occasion measures more than 140/90, but the patient is not having any hypertension mediated organ damage. But in contrast to that, sometimes patient may be having high normal blood pressure but having hypertension mediated organ damage. That's called masked hypertension. This one is a white coat hypertension. So there are 2 different things, right? So it depends which one is which, whether hypertension mediated organ damage is there or not, right? So ambulatory blood pressure monitor or home blood pressure monitor should be performed in suspected individuals, and the average 24-hour ambulatory blood pressure monitor should be less than 130/80. And average home blood pressure monitor would be less than 135/85 to confirm the diagnosis for the white coat hypertension. Assessment should be done to identify cardiovascular disease risk factors and HMOD. So hypertension-mediated organ damage is the damage that occurs in the brain, heart, kidney, central and peripheral artery, and eyes due to hypertension. So it's easy for you to now say brain, stroke, heart, ischemic heart disease, kidneys, chronic kidney disease. So this is hypertension-mediated organ damage. We are discussing about a chronic sort of a thing. Now say there is an acute hypertension-mediated organ damage also. I will come later. So hypertension-mediated organ damage, brain, heart, kidney, central and peripheral arteries, mainly peripheral vascular disease, and eyes due to hypertension. So hypertension mediated, why it is important? We have to detect it to prevent this hypertension mediated organ damage and treat the hypertension effectively. It's more common with long-standing hypertension and severe hypertension. Not always. Sometimes you can have with the lower blood pressure also. What is the condition I told? Masked hypertension. So sometimes very uncommonly you can have hypertension mediated organ damage in a high normal blood pressure, but generally it is with severe hypertension and a long-standing hypertension, right? very uncontrolled hypertension for a longer period, the damage is more. So basic screening, how do you evaluate that? You do the fundoscopy and see whether there is any hypertensive retinopathy. ECG, you can see whether there is LV hypertrophy, ischemic changes, and urine analysis, you can see whether there is proteinuria, creatinine, whether it is high, EGFR is low. Clinically indicated cognitive function testing you can do, echocardiography you can do, abdominal ultrasound, whether there are chronic contracted kidneys, Doppler studies, carotid ultrasound you can do, whether there is a significant damage, ankle brachial pressure index, you can see whether there is any peripheral vascular disease. So you can do this investigation also. So basic test, and after that you can do some specific tests. What are the manifestation of hypertensive mediated organ damage? Here, transient ischemic attack, stroke, ICH, aneurysmal subarachnoid hemorrhage, dementia, vascular dementia. Sometimes they come with a step-ladder pattern. So, see, then what is the assessment you will do is CT scan or MRI. Not recommended for routine practice now, unless the patient is having any symptoms of that. Heart, left ventricular hypertrophy, left ventricular dysfunction, ischemic heart disease, angina, acute coronary syndrome. ECG is recommended. LVH can be detected, two-dimensional transthoracic echo can be done. Kidney, albuminuria, CKD, serum creatinine, EGFR, we do. Arterial system, peripheral vascular disease, the lower extremity arteries, the ankle brachial pressure index, we have to do. Eye, fundoscopy, retinal arterial narrowing or sclerosis, AV nipping, exaggerated arterial light reflex, retinal hemorrhages, we do. Fundoscopy to screen for hypertensive retinopathy. Now we'll move on to the third case, 85-year-old male, hypertension, present to ED with generalized clonic seizures, afebrile, medications are prazosin, 2 mg TDS, HCT, 50 mg MANE, blood pressure 148/95, pulse rate of 110, severely dehydrated, sodium is 108, potassium 2.5, venous gas metabolic alkalosis, creatinine 150, full blood count, CRP, NCCT brain normal, there is no evidence of sepsis. The HCT, isn't it? The HCT, now say, what is the problem with the HCT? HCT is a recommended treatment in this age group. What is the problem with the HCT here? The dose is the problem, yes. HCT, our experience with HCT in Anuradhapura is, now we can name it as a killer drug in this dose, right? So even we see a lot of clinic books saying 50 mg MANE, even 25 mg MANE, we tend to see there are a lot of hyponatremia and we are managing that. So my best advice would be to don't go beyond HCT 12.5 MANE. So it's the side effects are more with the higher doses. So if the patient can afford, they can go for indapamide or clothalidone. Like if the patient can't afford HCT, always stick to the lowest possible dose, which I think even the commercial preparation, the combined preparation, they have 12.5 MANE, losartan 50 and HCT of 12.5 MANE. So I have never seen a 25 dose in a commercial preparation. Now say other like losartan HCT combinations. So that is the dose which is the problem in this patient. And any other problems in this patient? The HCT with the higher dose causing severe, the dehydration as well as severe electrolyte disturbance causing seizures. That is one problem. Any other problem you can pinpoint? The first line medicines are, that's the most important part, isn't it? First line is whether ACE inhibitor or ARB. That's number one. Number two, calcium channel blocker. And third one is thiazide diuretic. So thiazide diuretic we can accept if the dose is appropriate. That is one. And the prazosin is now say taken as a first line here, isn't it? Without other medicines. So and it will in this 85-year-old it will cause significant hypotension and fall, right? So this combination is not good. And the other thing is, and the dehydration. Okay, so that is so how to select antihypertensive is the next question, isn't it? Which patient need which, right? So these two slides are important, right? If you can remember these two slides, you can manage your patients very well, right? So establish the diagnosis of hypertension and do the lifestyle intervention. All the time you ask the patient to adhere to the lifestyle modification. So whether this is a grade 1 hypertension or grade 2 hypertension, that is the question. So what is grade 1 hypertension? If I ask anyone, grade 1 hypertension is, what's the value? Hypertension is above 140/90. So grade 1 is, you add 20 for the 140, that's about 140 to 159. Add 10 for the diastole, that's 90 to 99. So if that is the value, you grade 1 hypertension with whether there is a low to moderate cardiovascular risk, right? Still, you don't need to start treatment. Even though it's a grade 1 hypertension with low to moderate cardiovascular risk, you can drug treatment 3 to 6 months after the lifestyle intervention. After the lifestyle intervention, if the blood pressure is not controlled, then you have to start the medicine, right? That is grade 1 hypertension. If the grade 1 hypertension with high cardiovascular risk, so what are the conditions which has high cardiovascular disease? Diabetes, CKD, and hypertension mediated organ damage or estimated cardiovascular risk of more than 20%. If any one of this there, then we have to start the treatment. And grade 2 hypertension, what is the value? 160 there to 179. And 140/90 is now you are adding 10 and then another 10 there. So 100 to 109, isn't it? So 160 to 179, 100 to 109. That's a grade 2 hypertension. You immediately start treatment. Okay. So, and the next slide is again low risk grade 1 hypertension. Patients more than 8 years, patients with frailty. If yes to any of that, go for the monotherapy. Okay. So the left side, you can see the monotherapy. It has to be any one of that. Or that means ACE inhibitor ARB or dihydropyridine calcium channel blocker or thiazide like diuretic. Right? So you can go for that. All right. So if you are not happy, you can give indapamide SR, but it's now say you can't practice that in your hospital practice. You can go for HCT in a lower dose. So either one of that can be given. If no to all, now say if the patient is having a moderate to high cardiac risk, or patient is young, or patient is not frail, so you have to start dual low dose combination. Why? This is proven. Dual low dose combination is proven rather than going for a monotherapy. That multiple mechanisms are acting and then having a good blood pressure and the mortality benefit, right? By trials. So what do you start? ACE inhibitor ARB plus dihydropyridine calcium channel blocker. That is one combination. Or ACE inhibitor ARB or thiazide like diuretic, right? Or thiazide like diuretic plus calcium channel blocker. You have 3 drugs. You can combine these 3 options are there. Okay. So with the low dose, you can go over dual low dose combination for a grade 1 hypertension. And then you have the step. Now the blood pressure is not controlled. What do you do next? Then you have to go for the step 2. The step 2 is dual full dose combination. Same first line agents are there. These 3 medications are first line agents. You can combine these agents with the way, and then you have to go for a full dose. Now the blood pressure is not into your target, then go for the 3 drug combination. All 3. ACE inhibitor or ARB, thiazide like diuretic, and a dihydropyridine. You go for 3. Now this is not controlled. Now if the step 3 is the blood pressure is not controlled, what is it called? Resistant hypertension. Then you go for the 3 drug combination plus spironolactone. Now there's the other. Now even though this is not controlled, now you add the other drugs like alpha blocker and beta blockers has to come later, right? So contraindication you need to know, right? So pregnancy is important. Now say ACE inhibitor ARB, pregnancy is important. Sometimes ACE inhibitor and ARB can be combined or not. ACE inhibitor and ARB can be combined. Generally, it is not advisable. Some trials show that it can be, but it is more harmful rather than the benefit, right? So kidney injury and hyperkalemia risk is high. So ACE inhibitor ARB should not be combined. angioneuritic edema, bilateral renal artery stenosis, severe hyperkalemia for ACE inhibitors, ARB pregnancy, bilateral renal artery stenosis, severe hyperkalemia, beta blocker asthma, pulse rate less than 50, second and third degree heart block, untreated pheochromocytoma. And dihydropyridine calcium channel blocker, mainly amlodipine, nifedipine. So tachyarrhythmia, MI within 1 month is contraindication. Significant aortic stenosis is contraindication. You have to know this before. You have to make sure that these contraindications are not there before you prescribe, right? Pulse rate of less than 50, second, third degree heart block, heart failure. Thiazide diuretics, sodium, potassium are markers. So generally, whenever you have hypertension, at least you can do annually at least electrolyte. If you can 6 monthly, something like that, it's better to check the creatinine and see how the creatinine trend is there in your clinic patients. Now, say if you can once a year, you can do that, right? Do not delay that once a year, but frequently, like 6 months at least. So we know what is happening with the patients, whether the patient is having some CKD or AKI happening and electrolyte disturbance are there. You can document that, detect that early and treat it, rather than later until the patient developed a generalized tonic-clonic convulsion or a seizure, coma, irreversible damage. So before that, just screen in your clinic patients whether once a year the electrolytes or creatinine, the basic investigation has to be done. Even from your GP practice, you can do that, say as a screening, right? So mineralocorticoid receptor antagonist, spironolactone, hyperkalemia, eGFR of less than 30. So alpha blockers, history of postural hypertension, micturition syncope is contraindicated. So the next case, 65-year-old female was transferred from peripheral hospital for the control of blood pressure, attended the routine medical clinic at peripheral hospital. The patient is asymptomatic. The doctor has seen and the blood pressure 200 by 120, packed the patient into the ambulance and sent to the teaching hospital, Anuradhapura, for the further management. What is your opinion on this patient? You are seeing in this hospital. Main question you need to ask is whether this patient is having a acute hypertensive mediated organ damage, not the chronic, right? Acute hypertensive mediated organ damage. If it is there only, you need to treat inpatient with the IV medication to control the blood pressure. So most of the transfers are happening from the peripheral hospitals, in GPs are admitting. So whether this is an unnecessary cost to the health system, and the patient, now say the patient is not compliant, says want to take the medication and go home, but you are just troubling the patient to sending the patient for a tertiary, it can be prevented. So this patient does not need any transfer. The patient is having most likely a hypertensive, not having a hypertensive mediated organ damage. If you are in doubt, you can do that and see, but not definitely an acute hypertensive mediated organ damage, right? For the IV drugs, okay, to control the blood pressure quickly, right? Because no headaches, no confusion, no low urine output, no chest pain, no strokes, nothing there in this patient. So this falls under hypertensive urgency. So hypertensive emergency is an elevated systolic, so severe hypertension, mainly more than 180 by 120 or more, confirmed on repeated measurement with evidence of acute, that's important, acute hypertensive mediated organ damage. In asymptomatic with elevated SPP more than 180, 120 with no evidence of acute HMOD, the term hypertensive urgency is used, which would essentially be treated as outpatient. Right? You have to control, you have to titrate the medication and send home. So clinical features of HMOD, CNS damage. So sudden onset confusion. If a patient with a sudden onset confusion and the high blood pressure, you have to think of, right? Hypertensive encephalopathy, blurred vision, papilledema, suggestive of hypertensive encephalopathy, clinical features of ischemic or hemorrhagic stroke, SAH. Renal damage, sudden appearance of a gross proteinuria or oliguria, suggestive of AKI. So the acute kidney injury has to be there. Cardiac damage, acute chest pain, dyspnea, suggestive of acute coronary syndrome, heart failure, or aortic dissection. Retinal damage, a sudden and progressive deterioration of vision with accompanying retinal hemorrhage and or exudate. So nothing there for this patient. So this is not falling under emergency, hypertensive emergency. So there are several drugs for managing hypertensive emergency. The common one which is available with us are labetalol and GTN. So better to know the drug doses, because we do a lot of stroke thrombolysis. So we tend to use labetalol, which has alpha and beta adrenergic blocker. IV loading dose of 20 milligram over 2 minutes. That's a loading dose. Okay. Incremental dose of 20 to 80 milligram at 5 to 10 minute interval. Maximum total dose of 200 milligram. Right. IV infusion of 1 to 2 milligram per minute. So you can give a bolus dose and start infusion, or you can give several bolus. So what are the conditions you can use this? Neurological emergencies, mainly stroke, aortic dissection is important. You have to use labetalol, pre-eclampsia and eclampsia. So generally labetalol we don't use it in pulmonary edema, right? So the next drug, GTN, we use it when the patient is having ischemic heart disease and acute coronary syndrome with pulmonary edema. GTN is the best. The contraindication or caution is for labetalol: bradycardia, pheochromocytoma, left ventricular failure, and pulmonary edema. GTN, venous vasodilator, IV infusion, you have to go. It's better to know these numbers, 500 to 200. You can go up to 200 microgram per minute. You can start low and go slowly. You have to increase the dose, 5 to 50 micrograms per minute. So acute coronary syndrome and LVF are the indicated clinical situations. Contraindication is concomitant phosphodiesterase 5 inhibitors, raised ICP. Now, in a stroke, acute ICH, how do you manage the blood pressure? Again, the systolic blood pressure more than 220, right? Then you treat the patient with systolic blood pressure lowering with continuous IV infusion and close blood pressure monitoring. For that also, you have to go for a 15% MEP reduction. So SBP 150 to 220. So the lowering to less than 140 is not recommended. So whenever you treat the emergency when the blood pressure more than 220, you can control the blood pressure even below that, but do not lower below 140. So this is for the ischemic stroke. Now say the question is whether the patient qualifies for thrombolysis or not. So again, there are several values. This hypertension guideline is now say values. It's better to remember these values. So what is the value if you want to control this? Lower the systolic blood pressure to less than 185, diastolic blood pressure of less than 110. So you can remember the severe hypertension is 180, 110, isn't it? So just 5 for the systolic, adding only 5 for the systolic. So you control below that range and then you give the thrombolysis and maintain that 5 below, that's 180 by 105. So it's better to remember that. And if there is no thrombolysis is indicated, then you go by the 220 by 110 mark. If it is more than that, if there is more than 220 by 110 in a stroke condition, you go for a lower the MEP 15% during first 24 hours. So MEP reduction has to be 15%, right? So you don't need to control with the GTN or labetalol infusion to the normal blood pressure. If you are doing that, you are asking for trouble. Like you are increasing the ischemic penumbra, the stroke will evolve. Now say the stroke will get deteriorated. Now the patient clinically will deteriorate because of this ischemia. So because generally these patients are more in favor of they have the chronic hypertension. So chronic hypertension, their brain is adapted to that chronic hypertension. You are doing that, you are controlling that within very few hours, you are making it normal, the patient will deteriorate all of a sudden. So even though it is a hypertension emergency, your MEP has to be reduced 15% during the first 24 hours. So remember that, that's an important point you need to remember, right? And if that is less than 220 by 110, so initiating or reinitiating treatment of hypertensive medication within the first 48 to 72 hours after an acute ischemic stroke is ineffective to prevent the death or dependence. For pre-existing hypertension, reinitiate antihypertensive drugs after neurological stability. The next case, 42-year-old male who has diabetes, hypertension, dyslipidemia, no history of angina, blood pressure 160 by 100, HbA1c of 9.2, LDL 200, no ischemic changes. So how do you manage? So the systolic blood pressure target should be 120 to 129 in patients less than 65. This patient is 42-year-old. So you have to maintained within 120 to 129, not less than 120, right? So systolic blood pressure target should be 130 to 139 in patients above 65. For those more than 8 years, the systolic blood pressure target should be 130 to 139, provided the treatment is well tolerated. Diastolic blood pressure target should be less than 8, right? So generally keep you don't reduce it below 120/70, right? So why? How do these the researchers, they take these targets? How do they get the targets? Similar to diabetes, they see the complications of hypertension mediated organ damage. So up to what point these are very minimal. So they try to make the target, but not compromising their clinical conditions. Now, say if they are too lowering, the patient will have hypotension and they falls and everything. So we need to have a balance. So what they are generally advising is to do not lower below 120/70. So above that, but if it is younger patients like less than 65, it's 120 to 129. If it is an older patient, 130 to 139. So even more than older patient, more than 80, 130 to 139, if it's individualized now. Sometimes the patient may not tolerate. In an 85-year-old man can't tolerate. If you're thinking 135, then you can give a liberally higher target. So it's all, you can individualize, but this is more of a generalized. So statin therapy and antiplatelet therapy, high intensity statin therapy is recommended for secondary prevention in patients with established cardiovascular disease. Moderate intensity statin therapy is recommended for primary prevention in those with LDL cholesterol of more than 190, diabetes along with hypertension, 10-year cardiovascular risk more than 20%, CKD. So we are giving a moderate like atorvastatin 20 or rosuvastatin 10. So high intensity therapy if there is an established CVD. Antiplatelet therapy is indicated for the secondary prevention in patients with cardiovascular disease. In hypertension, antiplatelets are not recommended for the primary prevention of cardiovascular disease. Thank you.